Hello, I'm Dr. Akhil Tawari, consultant orthopedic spine surgeon, meeting you once again. So today I'll be talking about a condition called as cervical myelopathy. I'm sure this sounds like a very scary term, and trust me, if we don't take special precautions or don't manage it properly, then it can lead to devastating complications in patients. Now, first I would like to explain what cervical myelopathy is. So I'll explain to you on the model. So if we pay attention to the spine model, this is the neck area, this is mid back, and this is lower back. Now cervical myelopathy, cervical means neck and myelopathy means the problem with the spinal cord, which is the yellowish structure that you see inside. Now spinal cord is the most important nerve that is running all the way from the brain and with small nerves supplying the arms and legs. So at the level of the neck, if for some reason the transmission of electric signal is hampered, then that results in a condition which is called as cervical myelopathy. Coming to what the patients would feel when they are suffering from this condition. So we have patients who are elderly who present to us with difficulty in walking. They say that, doctor, we are not able to walk straight, or we feel wobbly or balance issues while walking. We have certain patients who present to us with objects falling from the ground, or they specifically say that their signatures are now different. They have problems in doing fine movements such as buttoning or unbuttoning the shirt or the blouse, and that usually is the first indicator towards something bad that is lurking either in the spinal cord or in the brain area. Whenever the patients present to us, we first like to do a detailed evaluation. So the patient's range of movements at the neck as well as the thoracic and the lumbar area is checked. We do a detailed neurological examination. There are few tests that we do which are specific for cervical myelopathy. So there is a test which is called as Hoffman's test, in which we do the jerks in the upper limbs, and there is a jerky movement that the patients elicit. We tell the patients to walk in a straight line and they are unable to do that, which is the tandem gait sign. Once we have a suspicion, we usually like to investigate it further. We start with x-rays in order to know the normal alignment of the spine, but more often than not, we go to the standard of care as far as diagnostic imaging is concerned, and which is an MRI scan. The MRI scan tells us about the gravity of the problem. It first tells us whether the cord is involved or not. Secondly, it also tells us whether there is myelopathy, that is initial involvement of the spinal cord, or there is myelomalacia, which is late involvement of the spinal cord. This is extremely important as far as treatment and prognosis goes. If there is early involvement, then we can reverse it. But if there is late involvement, then usually the problem for the patients become irreversible. Now, what causes it? That's a very interesting question to answer. So, just like there is wear and tear of the body parts, similarly, at the level of the spine, there is degenerative conditions that progress. And when they progress beyond a certain limit, they interfere with the canal dimension. So, by the canal, I mean the space that is available for the spinal cord. If they reach a critical value, they start impinging on the spinal cord, and that's when the problem of cervical myelopathy starts. Apart from that, it can also be secondary to some trauma. There are certain patients who are prone to these conditions ethnically as well, and they have something called as OPLL, in which there is calcification of all the ligaments around the canal, and the patients will present in a similar way. Now, the treatment part is what to do. So most importantly, we need to pick these patients up quickly. Sometimes we have patients who present to us in a very advanced stage with myelomalacia, and unfortunately by then the problem becomes irreversible. So once we have a myelopathy, we need to see whether the patient's symptoms are static or they are progressing. So we keep the patients under close follow-up, preferably every 3 to 6 months. We also tell the patients what are the red flags. So by red flags means the patients need to come to me immediately if there is a deterioration in their functioning. If the patients have deterioration in their functioning, or if the problems are progressing very rapidly, then more often than not, we have to consider surgery for this condition. The surgery depends upon number of factors: how bad the problem is, where is the compression that is happening, either it is happening in the front or more so in the back, what is the overall alignment of the spine, and accordingly different surgeries can be offered to the patient. The surgeries are namely something called as ACDF, that is anterior cervical discectomy and fusion, or posterior cervical decompression and fusion. Sometimes we also do surgeries which are called as laminoplasty. There is also a surgeon preference to what surgery the surgeon would offer to the patients. It is important to note that when done properly, surgeries can definitely halt the progression of this problem. Sometimes they may also reverse the neurological issues that have set in. However, that is a little unpredictable